My favorite saying of late is, you see what you look for what you know, and you know what you read and experience. So having seen some of these cases, hopefully they'll stick with you now and in the future. Here are the unknown cases for you guys. Case number 1. Case number 2, again, these are GI-focused cases. Case number 3, right upper quadrant ultrasound. Case number 4, also in the right upper quadrant. And case number 5. What I'm going to talk about today is an overview of the pediatric abdomen. We'll talk a little bit about the newborn abdomen. We'll talk about some common urgent and emergent abdominal problems in children that you might see out of the emergency room especially, and also out of the newborn nursery. We'll talk about pediatric liver and biliary abnormalities, and the big topic of abdominal masses will actually be in the next talk. The newborn abdomen. The normal newborn abdomen is monotonous polygons of gas. What I use is the distance between the pedicles at T12 to determine what is my upper limits of normal, and that way you can sort of correct for gestational age and decide what's dilated and what's not. You cannot reliably tell small from large bowel except for the stomach and the rectum, and don't get led down that line because you will get messed up. Just because it's up against the right or left abdominal wall does not mean it's colon. So just remember, you cannot tell small from large bowel in newborns. First disease I'm going to talk about is necrotizing enterocolitis, which is an idiopathic enterocolitis in premature infants. It has a very high mortality rate of up to 30%. The etiology is unknown. People have thought that it might be hypoxia, infection, or related to feeding, because it's very unusual to see necrotizing enterocolitis in unfed premature infants. It may be that the feeding gives a substrate for the bacteria to grow with. The inflammation begins in the mucosa but can spread through the bowel wall. It's most often in the right lower quadrant, ileum, and right colon, but it can be anywhere. It's usually patchy, and there are a variety of signs and symptoms, anything from abdominal stention to a shocky baby. And this is case 5, which is necrotizing enterocolitis. If you look in the right lower quadrant, you can see pneumatosis, which is a bubbly pattern. Remember, newborn babies do not have formed stool. So if there's anything you think is formed stool in a newborn, think instead that it's pneumatosis. And that's what this sort of looks like. You may see it tracking along the wall, but you may not. And at least raise the suspicion if you see this bubbly pattern. Once you see the bubbly pattern, then you need to start looking for the other places gas can spread, which is, it can be picked up by the mesenteric venous system and spread to the liver and the portal vein, which you can see here. You can see gas in the portal vein, and here's a close-up of that. This is all you get. It's peripheral because the portal vein is going out into the periphery of the liver. And then the other thing that you look for is free intraperitoneal air. In this case, remember, these babies are laying on their backs when these exams are taken, so the air is going to collect in the least dependent part of the abdomen, which is up against the anterior abdominal wall. On every single baby film you ever look at, you should draw a line across from the right abdominal wall across, and it should always be the same density, the same degree of whiteness. If it gets blacker, be very suspicious that you have a football sign that you're dealing with free air. You can also see a nice example of Wriggler's sign here. Next thing I'm going to talk about is abdominal wall defects. There are 4 folds that go to close the abdominal wall. There's 2 lateral folds, a caudal fold, and a cephalic fold. If you get a cephalic fold defect, that's usually ends up with the pentalogy of Cantrell, which is congenital heart disease, ventral hernias, sternal defects, absent diaphragm, and a pericardial defect. You may get the more common ones are the lateral fold defects, and those can either be central or usually on the right. The more central one is the omphalocele, and the more lateral one, usually on the right, is gastroschisis. A caudal fold defect will result in cloacal exstrophy, which is omphaloceles, epispadias, and bladder exstrophy. So here's case number 2, which is an omphalocele. You could actually see the umbilical cord coming right into the apex of this mass in the mid-abdomen. It's a midline defect covered by peritoneum. the cord inserts into the apex. And you know this from doing your fetal ultrasound. You look very carefully, where is the cord, to try to determine what you're dealing with. The size and the contents are variable. It may have bowel, omentum, it can have liver in it. The big thing is 2/3 have associated other abnormalities, cardiovascular abnormalities, chromosomal abnormalities, often trisomies, and these kids usually have malrotation, although surprisingly very, very few ever end up with a volvulus. Gastroschisis is usually a lateral fold defect on the right, and it's thought to be probably a vascular insult. There are infrequent associated abnormalities, and it's usually only bowel in the defect. There's no peritoneal covering, and because of that, the bowel is hanging out in amniotic fluid, and that results in a real inflammatory response, and you'll get bowel shortening, and it'll clump together, and there'll be like this big, thick inflammatory peel that can cause problems for the infant after birth. Here's a nice example of a gastroschisis. Here you can see a soft tissue mass to the right of the midline, and you know that the cord is not going into it because here you can see the umbilical arterial catheter to the left of this mass. Okay, enteric obstruction in the newborn. We're going to try to look at it from top to bottom, and we're going to come up with differentials that are based on where we think the level of obstruction is. Esophageal atresia is usually associated with a tracheoesophageal fistula, and this is a very, very, very high up obstruction. You often suspect this before the baby is born because there's maternal polyhydramnios, because the baby can't swallow amniotic fluid in the usual manner. After birth, the baby will drool, will not be able to feed, will be choking, sometimes coughing and cyanotic, and when the clinicians try to pass an NG tube, they can't do it. Half of patients with esophageal atresia and tracheoesophageal fistula have associated abnormalities. The most common kind of esophageal atresia, tracheoesophageal fistula, is the proximal atresia, distal tracheoesophageal fistula. Air is a great contrast. We don't usually need to give the babies contrast from above to see the proximal atresia. Here you can see on this lateral chest x-ray there's an air distended pouch. Here's another baby where we can see they've tried to put an NG tube down. It doesn't go very far because it's in that proximal pouch. And we know that there's a distal tracheoesophageal fistula because we have air-filled bowel. And we can actually see some of the air in the distal esophagus here because this is tethered up to the level of the trachea. This baby, however, has the Vactral association and some of the other things you need to look for when you're looking at these babies that you know have an esophageal atresia and tracheoesophageal fistula. Here you can see this baby has segmentation anomalies with hemivertebra in the mid-thoracic spine. This baby also has dilated bowel throughout the abdomen, and that's because he had an imperforate anus. He has an enlarged cardiac silhouette, had a VSD. We knew that there was a tracheoesophageal fistula and esophageal atresia. You also look for renal abnormalities, limb abnormalities in the Vactral association, and not associated with the Vactral association, but in this patient you can notice that the hips are dislocated on both sides. You can have esophageal atresia without a tracheoesophageal fistula, and one place that's more common is in Down syndrome. And the way that you know that you have that is here's that esophageal catheter up in this dilated proximal pouch, but you have a gasless abdomen. There's no way for air to get into the stomach. That is also associated with other atresias, so as you start to evaluate those kids, you need to be looking for further down, duodenal atresia, small bowel atresias, etc. Everybody always talks about the H-type fistula, which is really N-shaped. It's a very rare abnormality, only accounts for 1% of tracheoesophageal fistulas, and in this case there's no esophageal atresia. But you'll see a connection, and it usually goes from the esophagus superiorly into the trachea. And so you need to be very careful when you evaluate these infants because you'll watch them swallow and all of a sudden you'll see the stuff in the top of the trachea and you'll wonder if you were really dealing with aspiration versus a tracheoesophageal fistula. One place that I think it really helps is if you see a baby that keeps coming in with recurrent pneumonias that you're thinking might be aspiration, and every time you look at that baby they have gas distended bowel, think about this type of fistula, because as easy as fluid can go from the esophagus to the trachea, air can go from the trachea to the esophagus. Okay, now we'll talk about obstructions that are a little further down. Intestinal obstruction is the most common abdominal emergency in the newborn period, and these kids may be prenatally diagnosed, or they may present with vomiting, poor feeding, and abdominal distension, or they won't pass meconium. What we're trying to do when we look at our plain films is decide, do we think it's a high obstruction, which is jejunum and above, or do we think it's a low obstruction, which is ileum and below? The upper obstructions can be gastric atresias or webs, pyloric stenosis, duodenal atresia, stenosis or webs, duodenal duplication cysts, malrotation and midgut volvulus, and jejunal atresia and stenosis. Duodenal atresia is a common abnormality that we see. The duodenum is a solid tube at 3 to 6 weeks of gestation, and if it doesn't recanalize, you end up with duodenal atresia. If it partially recanalizes, you'll end up with stenosis or a web. They mostly occur just distal to the ampulla of Vater, and so there can be associated pancreatic or bile abnormalities. Most people that do a lot of pediatric radiology don't think that an annular pancreas is a cause for duodenal obstruction, but it's an associated finding, and if you see an annular pancreas, you should think that there's probably an intrinsic duodenal abnormality as well. Duodenal atresia, think about other associated abnormalities. They can have other intestinal atresias. Not unfrequently, you'll have an esophageal atresia, tracheoesophageal fistula. They can have congenital heart disease. It's associated with Down syndrome in about 30%. So if you see a duodenal atresia, there's a pretty good chance that there is Down syndrome, but if you see Down syndrome, there aren't very many that have duodenal atresia. And then again, the Vactral association. Here's a nice example of a duodenal atresia. There's a catheter down. Again, air is great contrast. We see the double bubble sign with air in the stomach and the dilated duodenal bulb and no air distal to that. This baby did happen to get contrast, and I just thought it was a nice example to show you of what it looks like. Again, the air is the best contrast, and you can see it almost looks like the top of a frosty ice cream cone where that atresia has occurred. This baby did not have Down syndrome. The duodenal web is the recanalization of the duodenum was not complete, and there's a membrane with a hole in the center, and as material goes through it, it sort of drags this membrane, and you end up with this big windsock deformity coming down. And here you can see that. Here's that big dilated windsock deformity, and then beyond that, the duodenum is not dilated. Very common finding in trisomy 21. And these kids will have their milk, and when they're still just on formula or breast milk, they'll eat normally. But then as they transition over to solid foods, those tend to get caught. And so these kids will present a year and a half of life with their duodenal web. Okay, the most important thing I'm going to tell you about in this talk is bowel rotation, malrotation, and midgut volvulus. This is a life-threatening problem for infants. As you remember, the bowel herniates out into the yolk sac at 4 to 10 weeks of gestation, and then it folds back in with 3 counterclockwise 90-degree turns. And what that does is it results in the duodenal-jejunal junction being in the left upper quadrant and the cecum in the right lower quadrant, so your mesentery is nice and long, and therefore it can't twist. Every single upper GI that's done on a pediatric patient should include evaluation of this. And the way we look at it is both lateral and frontal. You can't use one or the other. You have to use both. And you want the duodenum. Remember, the duodenal bulb is still intraperitoneal, but beyond that, it's a retroperitoneal structure at the descending transverse duodenum and the ascending duodenum. The junction of the fourth portion of the duodenum and the jejunum should be posterior and then to the left of the midline at the same level as the duodenal bulb. And you should always look for that. I'd say that there are a few diagnoses. The farther I go, the harder they get to make, and malrotation is one of them. There are a lot of subtleties to this diagnosis, but you need to be looking for it on every single case. If the bowel doesn't fold in properly during that 4 to 10 weeks of gestational age, you can end up with a very short mesentery. At the root of that mesentery is a superior mesenteric artery and vein. And if there's only a little pedicle, the bowel can twist on itself, and that's a midgut volvulus. It is a true surgical emergency. 3.5 twists leads to cutting off the arterial supply to the small bowel, and you can't live without your small bowel. This is a copy of a angio that was done in South America on an adult who obviously was having mesenteric ischemia, and you can see the twist of this midgut volvulus. 75% of patients who are going to have a midgut volvulus do so in the first 6 weeks of life. That means 25% present other times, and I've seen in my own career, a woman in her second trimester of pregnancy have a midgut volvulus, a kid be sent to a psych unit for intermittent psychogenic vomiting that was actually having intermittent volvulus. And my partner that was a gastroenterologist, a pediatric gastroenterologist, diagnosed his mother-in-law. So you always have to think about it. And the hallmark is bilious vomiting. The diagnosis is made with an upper GI, not a barium enema. This position of the cecum, if it's abnormal, can help you, but you can have a normally positioned cecum and still have malrotation of the midgut. So here's a 5-day-old girl who was normal and then developed bilious vomiting. You can see that there's a proximal obstruction. We have a lot of air in the stomach, not much distally, although there is a little bit. When we put the contrast down, and it's fine to use barium, you can use Omnipaque if you want. You don't want to use gastrografin because if a baby aspirates gastrografin, it can be very toxic to the lungs. You can see the duodenum coming out posterior, but then you can see this whirlpool sign. You do not see that normal position of the duodenum being posterior on the lateral view. This is case 1, which is jejunal atresia. We see a disproportionate bowel gas pattern with a few dilated loops, so we think it's a more proximal obstruction rather than a lot of dilated loops, which would suggest a distal obstruction. So this is a jejunal atresia. And then the other thing I wanted you to notice here is that there was an in utero perforation because we have a meconium pseudocyst with meconium peritonitis that's calcified here. Okay, distal bowel obstruction, lots of dilated loops. The way I like to think about it is you can start at the ileum and think of causes and go forward to the rectum, or you can start at the anus and go backwards. But the things that you're going to need to think about are ileal atresia and stenosis, meconium ileus, colonic atresia, functional immaturity of the colon, which used to be called meconium plug or small left colon, Hirschsprung's disease, and imperforate anus. The study of choice in evaluating a distal bowel obstruction is a contrast enema. And the question you're trying to answer is there a microcolon? If there is a microcolon, that colon is unused, the succus entericus has not made it there, and that will suggest that the obstruction is at the level of the ileum. So here's a patient who has dilated bowel, especially on the right. When we do the contrast enema, we can see that there is a microcolon over to the right, and then we have a few loops of ileum filling, and then beyond that, dilated bowel. This is an ileal atresia. And this is a good case to point out that you might want to say that that's the right colon. It's not. You can see here's the right colon. That dilated bowel is small bowel. You can't tell small from large bowel in a newborn. Meconium ileus is highly associated with cystic fibrosis, and it's due to inspissation of the thick abnormal meconium in the ileum and right colon in kids with cystic fibrosis. There can be complications. That thick blob of meconium can be the lead point for an intussusception. It can twist on itself, or you can end up with perforation. Here's an example of a meconium ileus. Again, a low obstruction, dilated bowel throughout the abdomen, lots of loops. When we put contrast in from below, we have a microcolon, a small caliber colon over to the right where we start to see a lot of filling defects back in the right colon and into the right ileum, into the ileum. Here's another case, a microcolon with filling defects as we're coming back here in the distal ileum. This is one of the things where radiology can be not only diagnostic but therapeutic. We can use water-soluble enemas to try to break up that meconium and get the baby to pass it. And it's successful about a half of the time, but it can take repeated enemas to do that. Different radiologists vary on what contrast you use. Some people say you have to use gastrograph, and some people want to put mucomist in it. I think it's just anything that has a lot of water in it. I use diluted hypaque cysto. And again, you may need to do serial enemas. The perforation rate is about 3%, but if you can get this to pass, you save the baby an operation. Colonic atresia is rare. It's evenly distributed throughout the colon. It's probably a vascular injury, and it can exist with other intestinal atresias. Here you can see a microcolon to the level of the splenic flexure, and then a blunt end, and that's all that the contrast would go, and that's a colonic atresia. Functional immaturity of the colon is there's abnormal colonic motility. It's usually seen in either mothers that were on mag citrate or babies that are infants of diabetic mothers. There's no association of functional immaturity of the colon or meconium plug with cystic fibrosis. The only thing that meconium plug and meconium ileus have in common is the word meconium. Functional immaturity of the colon, again, a distal bowel obstruction, dilated bowel, lots of loops, and when we put contrast in, we can see that we see a small colon to the level of the splenic flexure, and then it's more normal caliber beyond that. You may end up seeing a meconium plug, which is this big, thick piece of meconium in the rectosigmoid or descending colon, and this is another case of functional immaturity of the colon. Often the babies will pass these when they're in the radiology suite. They are some of the weirdest looking things you've ever seen. They can be white and yellow, and they don't look like what you'd expect them to look at. And the baby will start stooling normally as soon as they've passed that. Hirschsprung's disease is arrest of the craniocaudal migration of ganglion cells into the distal bowel. So if you don't have ganglion cells, your bowel cannot relax. Because the cells are migrating from caudad to cephalad to caudad, wherever they stop, there's no ganglion cells beyond that to the level of the anus. It's more common in boys. It's very uncommon in premature infants. And it's more common in children with Down syndrome and also children with congenital neuroblastoma. Here again, you see a distal bowel obstruction, multiple dilated loops of bowel, and when you put contrast in the rectum, you can see a small caliber rectum with the sigmoid being larger. The rectum should always be bigger than the sigmoid. This is one of my 3 diseases, with malrotation being one. Hirschsprung's disease, from a making the diagnosis using radiology standpoint, to me gets harder the more cases that I see. It is not always straightforward. And if there's good clinical symptomatology for Hirschsprung's disease, even if I don't see anything on the enema, I think they should still biopsy those patients, because I think this can be a very tough diagnosis. If you see this, that's very straightforward, but not all cases are like that. Now, one other thing I will caution you with is that you can't always tell where the transition zone is in Hirschsprung's disease, and the transition zone can be anywhere. And this is a case where you'd say, oh, gee, this looks just like the case you just showed me of small left colon or functional immaturity of the colon. But this was path-proven Hirschsprung's disease. So whenever I see what I want to call a small left colon, I always at least talk to the clinician and say, look, if now that I've done this enema, this baby doesn't start stooling normally, think about Hirschsprung's and consider biopsying. Hirschsprung's can involve the whole colon. It can involve the whole bowel, in fact. And here you can see a baby that has a distal obstruction, lots of dilated loops. When you look at the colon, the rectum is bigger than the rest of the colon, but the colon is very short looking. It's like a question mark kind of colon. And it's very featureless, and that's a clue that you might be dealing with total colonic aganglionosis. And again, a biopsy will confirm that diagnosis. Imperforate anus is usually not a diagnostic dilemma, but the important thing for you is to try to figure out sometimes if it's high or low, and then to look for the associated abnormalities, which can be renal abnormalities or spine abnormalities, especially if it's a high imperforate anus. Occasionally, some surgeons will want to know what you think the level of the imperforate anus is. This one is clearly low. You can see air coming all the way down, very low in the pelvis. But often there's meconium in there, and that sort of obscures your view. Some will want a prone cross-table lateral view, and you draw a line between the coccyx and the pubis and see if you can see air below that. If you do, then it's a low imperforate anus. Sometimes we'll be asked to do VCUGs, looking for the rectourethral fistula. Here you can see it. That will only be in male infants, because if there's a female infant, the fistula will be into the vagina. And here's a baby that you can see that there is a fatty phylum, and the baby also had an imperfect anus. Common urgent and emergent problems, pyloric stenosis. Seen in babies usually 1 week to 3 months of age, but it can be seen younger. It has been seen in stillborns, more common in boys, more common in white infants. Non-bilious vomiting is the hallmark. Today, nobody waits long enough for you to be able to palpate an olive. They bring the kid in pretty much the first time they vomit, and usually they'll get in before there's electrolyte abnormalities as well. It's thickening of the circular muscle layer of the pylorus. Here you can see a baby that has a disproportionate proximal bowel gas pattern obstruction, gas in the stomach, a little bit of gas beyond that, but it's a high level of proximal obstruction. Study of choice is an ultrasound. Here's a normal pylorus where you can see the echogenic mucosa, fluid-filled pylorus, thin hypoechoic muscle layer. You can actually see the duodenal bulb here. Pyloric stenosis, usually when you put the transducer down, you can see this big thickened pylorus. It looks like a cervix. Here's the mucosa. Here's the muscular layer. And you can actually see the muscle shouldering back and going into the antrum of the stomach. Different people will give you different numbers, but I like 3 millimeters for a single wall thickness and more than 15 millimeters for the length of the pylorus to call pyloric stenosis. Hopefully you'll never have to do an upper GI because these take about 26 years because they have a gastric outlet obstruction. Acute abdominal pain in children, very common. And often the most common etiology is abdominal pain of unknown cause and gastroenteritis, neither of which are radiological diagnoses. But the third one, appendicitis, is. And just remember that other things can cause abdominal pain that aren't even in the abdomen. So always remember to look at your KUBs for a basilar pneumonia, especially in kids, because they will complain of abdominal pain when they really have pneumonia. And even pharyngitis and otitis can cause abdominal pain in kids. Appendicitis is common in kids, and it is difficult to diagnose because they haven't read the textbooks yet and they don't know how to present. It's common, and about half of cases will have atypical presentation. The white blood cell count is not elevated in about 10% with appendicitis. Plain films basically are not helpful. Ultrasonography is a great test in kids. Unfortunately, it's being drowned by the tidal wave of CT. I think that kids are usually skinny and they are optimum for being able to do ultrasound, but I think that clinicians are less comfortable with us doing the test, and you have to be good at doing it to do it, and because of that, CT is becoming very popular. The thing I think helps is to use IV contrast and rectal contrast when you're trying to diagnose appendicitis. Kids don't have a lot of intra-abdominal fat, so you need all the help you can get. The amount of rectal contrast I give is 100 milliliters per year of age, up to 1,500 milliliters. You use the same stuff you use for oral. And here you can see a nice normal appendix, and then typical findings of appendicitis, same as what you're going to see in adults. Pericecal fat stranding, a dilated fluid-filled appendix. Here's an appendicolith. Okay. Intussusception, again, a very common problem in kids. The bowel gas pattern can be anything. Don't be swayed by a normal bowel gas pattern and thinking that somebody doesn't have an intussusception. The one thing I will tell you is that if you see a constipated kid, they don't have an intussusception. The colicky abdominal pain causes the child to empty their colon, and so if you see that, you will not have an intussusception. Here you can see on a contrast enema the bowel rolled up on itself. That's a ileocolic intussusception, which is the most common idiopathic type of intussusception due to hypertrophy of Peyer's patches. It's more common in the winter and the spring because it's associated with viral illnesses. It's seen in children 3 months to 2 years of age. If you see a younger child or an older child, think about a lead point. Under 3 months of age, it's usually something like a Meckel's diverticulum. Older kids, it's usually lymphoma. Colicky abdominal pain is the typical presentation. They may have bloody stool. Lethargy is often common, and some of the sickest kids I've seen have had this very severe, shocky gray appearance and had an intussusception. They may or may not feel a palpable mass. Here's another child who has a small bowel obstructive pattern, multiple dilated loops of bowel, and That can be helpful, and it's helpful if you can see the mass, but the big thing you're looking for is there any evidence of peritonitis, free air, or pneumatosis, because that is what would stop you from doing a contrast enema on these kids. Ultrasound is a great test. If they don't feel a mass and you don't see a mass, then I suggest that you get an ultrasound before you go to the enema, because you save the child radiation if you don't find an intussusception. It's a very typical target appearance because of the hyperechoic mucosa, hypoechoic muscle. And it's folded up on itself so it looks like a target. It's somewhere along the course of the colon. It's 3 to 5 centimeters in size. It's not a hard thing to find. And the negative predictive value of an ultrasound is 100%. If you don't see an intussusception, there isn't one. You can use air or contrast for reduction. There's a small risk of perforation with both, a little higher with air than with contrast. But if you can't reduce the intussusception, then the baby needs to go to surgery. Liver and biliary tract. Jaundice can be unconjugated or conjugated. Unconjugated is usually associated with either a baby that's been bleeding or neonatal jaundice. Conjugated hyperbilirubinemia is something wrong with the liver. It can be neonatal hepatitis or biliary atresia, which are your two leading things that we're going to be asked to image for in infants. There are a lot of things that cause neonatal hepatitis. They can be infective. It can be inborn errors of metabolism. And surprisingly, even though these kids may be infected, they look clinically well, but they have conjugated hyperbilirubinemia. And when you look at them, they usually have a normal appearing liver and spleen on ultrasound, but it may be large. Bile duct canaliculi at biopsy are free of bile. We want to look first by ultrasound, and usually we will see a gallbladder. And usually the liver looks normal. If you see a gallbladder, it can be very helpful to feed the infant, because if the gallbladder contracts that and gets smaller, that means the extrahepatic biliary tree is patent. Here's another child who has a small gallbladder, but when they do a gallbladder cholangiogram intraoperatively, you can see that there is a patent extrahepatic biliary tree, and this was a case of neonatal hepatitis. Scintigraphy can be very helpful. You need to pre-treat these kids with phenobarbital to try to get their liver revved up to excrete the radiopharmaceutical. And there's 3 patterns. There's normal hepatic uptake, but no excretion, and that's what you see with biliary atresia. And then there's poor uptake and poor excretion, and that can be seen with a variety of diseases. The most common is hepatitis. It can also be seen with biliary atresia or stenosis and advanced cirrhosis. So neonatal hepatitis, at 60 minutes, we don't see any excretion by the liver, but at 24 hours, we do see excretion into the bowel that gets rid of the diagnosis of biliary atresia, and instead you're dealing with hepatitis. With biliary atresia, the extrahepatic biliary system is obliterated. It may be an infective etiology. You have periportal fibrosis, and these kids will look well, but they'll have a conjugated hyperbilirubinemia. At ultrasound, you usually can't find the gallbladder. Occasionally you can, but usually you can't. And the liver looks otherwise normal. So here's a child. Here we're looking at the portal vein, and we don't see a gallbladder. At liver scintigraphy, we can see that we never see any excretion out to 24 hours. There's a little bit of renal excretion that's normal with the IDA agents, but you never see any excretion through the liver. The treatment for this is a Kasai, and then once you've done the Kasai, you need to watch these patients because they'll get ascending cholangitis and portal hypertension, and so they usually by 3 years of age have to go on to liver transplantation. The last thing I want to talk about in the biliary tree is choledochal cysts, which are cystic or fusiform dilatation of the common duct, more common in girls. The classic triad of abdominal pain, jaundice, and a mass is not commonly seen. And it's probably because of a long common channel. That's the thought as to why they form. Know at least the general classification of the choledochal cysts. Type 1s are the most common, where there's fusiform dilatation, and here's an example of that, which is my case 3, where you can see fusiform dilatation of the common duct. Here's the gallbladder. Here's some mild dilatation of intrahepatic ducts. Here's a intraoperative cholangiogram showing the same thing, and here it is at CT. Here's gallbladder, and here's the choledochal cyst. So this is a quick run through of abdominal abnormalities in the pediatric population. So this talk is, I always feel like it should be, you know, a roller coaster ride. Keep your hands and arms inside the car and just hang on, because I'm trying to sort of do a little bit of all of pediatric radiology in an hour, which is a challenge. But I've tried to do it by looking at cases, starting at the head, going to the feet, and going through some interesting cases and interesting differentials and more common differentials. Here is some unknown cases. Case number 1. Here's case number 2. Case number 3. Case number 4. And case number 5. The first case I'm going to discuss with you is a newborn infant with congestive heart failure, and here you can see that there is marked enlargement of the cardiothymic silhouette and that there's also vascular congestion in the lungs. The child is intubated. The differential diagnosis of congestive heart failure in the newborn period includes several main categories. Left heart inflow obstruction, which would give you a normal-sized heart, things like total anomalous pulmonary venous return. A left heart outflow obstruction would give you an enlarged heart, things like aortic stenosis or a hypoplastic left heart. Muscle disease, cardiomyopathy, and non-cardiogenic causes such as electrolyte imbalances and peripheral AV fistulas. Here's an example of a child with a large heart and vascular congestion, and this one turned out to be hypoplastic left heart syndrome. But this particular baby, the first one I showed you, was also noted to have a cranial bruit. And here's the head ultrasound, coronal, here's cerebellum, temporal lobes, and you can see this large anechoic mass in the incisorial region that when you turn Doppler on this sagittal image here, cerebellum, nose is over here, you can see this marked Doppler flow within the lesion. Here are MR images of another patient with a similar finding, where we can see on this MRA, MRV that there is an arteriovenous malformation with dilatation of the straight sinus, and here again is that hypodense or anechoic absent signal region. This is a vena Galen malformation, which is an intracranial arteriovenous malformation. And the vena Galen is actually not really the vena Galen, but it's a prominent fetal vein that persists, and it carries the shunted blood, and that's why it's enlarged. Most present in the neonatal period. There's congestive heart failure because of the tremendous flow through this arteriovenous malformation, and they have a large fluid density incisoral mass. What other pineal region tumors are there? Well, you can have germ cell tumors, the most common of which is germinomas. You can have pineal parenchymal tumors, the most common of which is a pineoblastoma or primitive neuroectodermal tumor. Those are the same thing. You can have gliomas, and you can have malformative tumors such as dermoids or epidermoids. Here, for example, is a pineal region enhancing mass on this T1-weighted MRI after gadolinium, and this one was a pineoblastoma, and you can actually see that there's drop metastases with sugar coating of the ventral aspect of the brainstem, and here's some more nodular drop metastases at the midbrain. The second case is a child with recurrent TIAs and progressive neurological impairment. You can see on this T2-weighted MRI that there's multiple areas of wedge-shaped signal abnormality, mostly involving cortex, but also involving white matter, some areas of deep white matter signal abnormality, suggestive of ischemia and infarction, and the angio on this child shows a normal proximal internal carotid artery and then a puff of smoke above that. We lose our normal anterior middle cerebral arteries, but instead we have hypertrophy of the thalamoperforators and lenticulostriate vessels, giving us the puff of smoke appearance that's classic for Moyamoya syndrome, which is a progressive stenosis of the proximal intracranial vessels. Uncommonly involves the posterior circulation. Common in Asian patients, has also been seen in things like sickle cell anemia. Most patients are under 20 years of age, and they present with recurrent strokes or TIAs, progressive neurological impairment, and seizures. The treatment is basically they try to anastomose the extracranial to the intracranial circulation, and that's called encephalodural arteriosynangiosis. The next case is a premature infant with labile blood pressure and respiratory distress syndrome. And on this head ultrasound, you can see that there's a large area of hyperechogenicity surrounding and affecting and causing mass effect on the left lateral ventricle. In addition, you can see that there's increased signal or increased echogenicity in the right lateral ventricle, and the ventricle is dilated. Over the frontal region, you can see again this abnormal increased echogenicity in the parenchyma of the left frontal lobe. This is a grade 4 hemorrhage. Here's another patient that I've correlated the head ultrasound with a CT, and you can see this large acute hemorrhage in the parenchyma. You can also see blood layering in the occipital horn of the right lateral ventricle. Here on ultrasound sagittal, you can see this large hyperechoic mass, and here you can see the mass on the coronal view where there's obliteration of the normal sulci and gyri, and there's increased echogenicity. Neonatal intracranial hemorrhage is frequent in preterm babies, as high as 43%, and most of them are clinically silent, which is why we screen for this. It may be associated with periventricular leukomalacia, and it is the most common non-respiratory cause of death in preterm infants. It is also now the most common cause of cerebral palsy in the United States. The grading, and you should know the grading, is actually a clinical grading system not developed by radiology. Grade 1 is confined to the subependymal germinal matrix. Grade 2 is blood in non-dilated ventricles. Grade 3 is blood dilating the ventricles. It's not a dilated ventricle with hemorrhage in it. It is that the blood dilates the ventricle. And grade 4 is an intraparenchymal hemorrhage. The problem with this is you don't have to have a 1 to have a 2. Often you will go from 1 to 4. So what I like to do is describe the hemorrhage, and then in the impression, on each side of the brain, I'll give what is the highest grade that I see. Grade 1 hemorrhage, again, the germinal matrix sits in the caudothalamic groove, and if it's too bulky, here it is here, and here it is here sitting under the frontal horn. You compare it to the other side. That makes you suggest a grade 1 hemorrhage. Unfortunately for us, the choroid and hemorrhage are about the same echogenicity, so we can't always be 100% sure that we're dealing with hemorrhage. And sometimes I'll say, I don't know if it is or not. But if it's a big lump there, and I like to see it in 2 projections, then I'll go ahead and call a hemorrhage. You can see that this is a very preterm brain. There's not too many sulci and gyri. And you have to know the gestational age of the infant to be able to know whether you think you're dealing with abnormal brain development or not. If somebody told you this was a term baby, you would say, wow, there's something wrong here. But for a preterm baby, that's okay. Grade 2 hemorrhage is hemorrhage into the ventricle, which you can see here on this sagittal ultrasound. And here you can see it on the axial ultrasound, the left side up. And here you can see it in the ventricle in the frontal horn on the coronal view. Now, you should not have choroid in your frontal horn or your occipital horn. It should be in the body, trigone, and temporal horn. So if you see something you'd want to call choroid, but it's in the frontal horn or the occipital horn, call it blood instead. Here's a grade 3 hemorrhage where you can see that there's a big blood clot distending the ventricle. And so that gets you through the grading of neonatal intracranial hemorrhage. The next case is a 10-year-old with diabetes insipidus. And if you look on these T1-weighted MRIs, we can see the pituitary gland, we can see the infundibulum. Structurally, everything looks okay, but it's very important that you should always, always, always see a posterior pituitary bright spot on T1-weighted images in children, and we don't see that here. If you don't see that, and the child is not dehydrated, and especially if they have diabetes insipidus and you don't see a mass, bring the kid back in a few months, because here's that same child 6 months later, and this is a contrast-enhanced study, and now you can see the germinoma. Germinomas account for 65% of intracranial germ cell tumors in kids, and they're more common in the pineal region than in the suprasellar region. But if they are in the suprasellar region, you can have diabetes insipidus, emaciation, or precocious puberty as symptoms for it. What are other things that occur in the suprasellar region? Gliomas, either hypothalamic or optic, craniopharyngiomas, germ cell tumors like we just showed you. Histiocytosis can involve the infundibulum. You can have hamartomas of the tuberosynarium. Uncommonly, but you can have pituitary adenomas and malformative lesions such as Rathke's cleft cysts. Here's a patient on this close-up post-gadolinium MRI of the pituitary, you can see a thickened, enhancing stalk of the infundibulum, and on the same child, you can see that there's a floating tooth sign. This is histiocytosis. Craniopharyngioma can look like a lot of different things. Here on a CT, you can see a big calcified mass. On this sagittal post-gadolinium image, you can see this big fatty mass that's growing back over the clivus and actually flattening the brainstem. And then here's a more cystic appearing mass on this post-gadolinium image, and you can actually see a fluid level within it. So this can look like a lot of different things. Next case is a 3-month-old with a funny-shaped head. And here you can see that there's elongation of the head. And on the frontal image, you can see that we're not seeing the sagittal suture real well. Instead, it's looking heaped up and very sharp. And this is sagittal synostosis, which is the most common form of craniosynostosis, accounting for over half. The typical presentation is that the kid presents with dolichocephaly, which is also called scaphocephaly. Because the head can't grow side to side, it grows front to back. The fusion of the suture, if it fuses abnormally, usually begins at the mid portion and then moves anteriorly and posteriorly. Craniosynostosis is premature sutural fusion. It can be idiopathic, or it can be part of a syndrome or a result of other diseases such as rickets, certain syndromes. And if you take somebody that has a real big head, for example with hydrocephalus, and shunt them and the head collapses, the sutures can fuse as a result of that. The most common syndromes are Crouzon's and Apert syndrome, and you remember they have usually mitten hands, and so you can sort of ask about that if you're thinking you're dealing with craniosynostosis. Coronal synostosis is the second most common craniosynostosis, and the harlequin eye deformity, where the suture is tethered here so the eye can't grow in its normal shape, so it's sort of held up right there, is the clinical feature that you'll see on your skull films. And they also have a short head from front to back because the suture is closed and they can't grow front to back, so they grow side to side instead. Metopic synostosis gives you the quizzical eye deformity and hypotelorism, and that's because this suture is fused so the head can't grow side to side. If you look at them at a sort of a steep waters view, you'll see like a keel of a ship or trigonocephaly as well. Now, I've never seen isolated lambdoid synostosis. We get a lot of requests these days for rule-out synostosis because babies have flat backs of their heads. And it's because they're being laid on their back to reduce the incidence of SIDS. So when they sleep on their back. And usually the child will preferentially turn their head one side or the other, and that part will get flat. And what you'll see is that you'll be able to still see the sutures patent. You may see some lambdoid inversion, and you see flattening of the occiput. The thing that you don't see is if that lambdoid suture was closed and tethered, the ear would be pulled back. And you don't see that in these infants. If anything, the ear, when you look at the baby, will be pushed forward. But again, I can't show you one because I have never seen a case of isolated lambdoid synostosis. The next case is a 5-month-old with proptosis, and you can see on this CT scan that there are erosive changes of bilateral lateral orbital walls with associated soft tissue masses causing the proptosis. The differential diagnosis of orbital masses in kids is pretty long, but I think that you can narrow it based on the position of the lesion and what it looks like. Obviously, if there's infective symptoms, you could think about an abscess, or if there were infective symptoms, you can think about a pseudotumor. Benign tumors, teratomas, dermoids, and epidermoids can occur. Malignant tumors include rhabdomyosarcomas. Those will be in the orbit but not in the globe. Retinoblastoma will be in the globe. Optic glioma will involve the optic nerve. You can have leukemia, lymphoma, histiocytosis, and metastatic disease involving the bones around the orbit. You can have vascular malformations, fibrous dysplasia, and also enlargement of the muscles resulting from Graves' disease. Here's that particular child's CT scan of the abdomen, and you can see that there's a calcified paraspinous mass. This turned out to be neuroblastoma. There's an incidental splenic cyst. Neuroblastoma is the most common extracranial solid tumor of childhood and the third most common malignancy of children. The first is leukemia. The second is brain tumors as a group. These arise from the sympathetic neuroblasts of the embryonic neural crest, And so they can be seen anywhere from the base of the skull to the organ of Zucker-Kandel at the level of the bladder. And the most malignant is neuroblastoma, and it goes through a range from neuroblastoma to ganglioneuroblastoma to ganglioneuroma. And this is pathologically differentiated by the degree of cellular maturation. You need to know some staging system for neuroblastoma. I'd say you need to know staging systems for neuroblastoma and Wilms tumor. Whatever one you want to use, there's a bunch of them out there. The Evans one is pretty popular. Stage 1 is confined to the structure of origin. Stage 2, tumor extension in continuity, but does not cross the midline. Now you have to remember that the midline is not the midline. To me, the midline you draw through the middle of the vertebral body, and that's the midline. Their midline is if you go to the opposite side of the vertebral body along where the costovertebral junction would be, that's the midline, for whatever reason. Stage 3 tumor extension crosses the midline. Stage 4 is disseminated disease. And stage 4S is a primary that's stage 1 or 2, along with metastases to the liver, skin, or bone marrow in an infant that's under 12 months of age. Here's some examples of other tumors that we can see in the orbit. Here's another case of histiocytosis where we can see this irregular soft tissue mass centered on the lateral orbital wall. Here's a rhabdomyosarcoma of the soft tissues in the lid, actually, of the orbit, causing the globe to be pushed in. And here's a patient that has this large soft tissue mass with bony destruction involving the orbit, marked enhancement on post-gadolinium T1-weighted MRI images, and this actually turned out to be fibrous dysplasia. Here's another enhancing mass destroying the lateral orbital wall, but not very much destruction of that lateral orbital wall and causing proptosis. And this is a chloroma or a granulocytic sarcoma of the orbit in a child with AML. And this may be one place where you can look like a star, because if you see one of these, it may precede the diagnosis of leukemia. And this kid actually, it took 3 or 4 months. They kept treating him for orbital cellulitis before he finally popped up with his AML. Okay, the next case is a 9-year-old girl with a complaint of feeling like there's something stuck in her throat. And if we look at this lateral view of the airway, we can see that there's a large soft tissue prominence in the region of the base of the tongue, and here's the epiglottis right here. Here's aryepiglottic folds and vallecula piriform sinuses. So there's a soft tissue mass, and there's a differential for base of the tongue soft tissue masses that includes lymphadenopathy, lingual thyroids, vascular malformations, and rhabdomyosarcoma. Here's this child's CT scan, and you can see that this mass was hyperdense on the pre-contrast exam and enhanced a little bit, but not that much, on the post-contrast exam. If we look down in the region of the normal appearance, expected position of the thyroid, we do not see it. And when we do a pertechnetate scan, we can see salivary glands, and we can see this large area of increased activity at the base of the tongue, none in the position of the expected normal thyroid. So this is a ectopic thyroid, a lingual thyroid, which was case 1. Anomalies of the thyroid can include agenesis, ectopic thyroid, which is most commonly at the base of the tongue, but it can go all the way down into the suprasternal region. And you need to evaluate this, because if it's the patient's only functioning thyroid, they need to know that before they take it out. You can have thyroglossal duct cysts along the same track, along the foramen cecum, down to the suprasternal notch. The next case is a newborn with stridor. And you can see on this intubated child that the endotracheal tube and the esophageal catheter are displaced over to the left. We can see widening of the superior mediastinum with a normal-sized heart. At ultrasound, we can see a hypoechoic mass. Here's the sternum up here. And on CT, again, the airway is displaced to the left, and we can see this fluid-filled mass in the superior aspect of the mediastinum. The differential diagnosis of cystic upper chest and neck masses in kids includes cystic hygromas, vascular malformations such as venous malformations, branchial cleft cysts, paramedian thyroglossal duct cysts, though most thyroglossal duct cysts are on the midline. You can have suppurative adenopathy, you can have thymic cysts, and you can have duplication cysts of the esophagus. Cystic hygromas, which is what this case is, are macrocystic lymphatic malformations. They result from maldevelopment of the cervical and facial lymphatic system, and they're usually evident before birth or at birth. They may enlarge if they become infected or if they bleed into themselves, and treatment can either be sclerosis or primary excision. Branchial cleft cysts usually arise from the second branchial cleft, and they occur anywhere from the tonsillar fossa to the supraclavicular region. One very helpful clue that you're dealing with a branchial cleft cyst is that you'll see it interdigitate and separate the vascular bundle, carotid artery, and jugular vein. Here's a case of a child that had a large left neck mass, and you can see it here with an air fluid level within it, and this turned out to be a cervical esophageal duplication cyst. Here you can see when the baby was given contrast by mouth that cyst starts to fill. There was a proximal communication with the large cystic malformation. The next case is an 18-month-old with new onset asymmetrical wheezing. And you can see on this that there's asymmetry of inflation of the chest. I would actually say that the left lung looks bigger than the right, but when we do our forced expiratory view, the left lung collapses and the right lung doesn't. So there's air trapping on the right. And this is a foreign body aspiration, which was case 5. Most of the foreign bodies aspirated by children who are little vacuum cleaners are non-opaque, and they tend to be vegetable material, peanuts, M&Ms, pieces of hot dogs, pieces of carrots. And because it's the straightest shot right down the right main stem bronchus, that's where most of them go. Because when you breathe in, your bronchi get a little larger, the air gets past the foreign body. When you breathe out, your bronchi gets smaller, constricts around the foreign body, so air is trapped beyond it. You can have complete obstruction and result in distal atelectasis. Here you can see that there's a radiodense foreign body in the bronchus intermedius, and we have collapse of the middle lobe and lower lobe. And this was, I've seen actually several cases where motor vehicle accident patients have aspirated teeth. So always watch for that in the kids that come in and adults from motor vehicle accidents, especially if they've hit their face on the dashboard. Newborns, next case is a newborn with mild respiratory distress. And we can see that on this chest x-ray, we lose the left hemidiaphragm shadow on the frontal view, and on the lateral view, we can see a mass-like density posteriorly on the left. The differential diagnosis of chest base masses would include, especially on the left, a sequestration, a solid cystic adenomatoid malformation, diaphragmatic hernia, hiatal hernia, neuroblastoma, a parenchymal bronchogenic cyst, and metastatic disease. Here's that child's MRI. These are T1 weighted images, and we can see the large feeding vessel going to this lesion off of the aorta, and we can actually see the drainage from this mass in the left lung base back into the region of the coronary sinus. So this is a extralobar pulmonary sequestration. This is part of the continuum of a pulmonary developmental abnormalities that starts with totally abnormal lung, but normal vessels on one side, which is congenital lobar emphysema, all the way through to completely normal lung, but abnormal vasculature, which is a pulmonary arteriovenous malformation. Extralobar pulmonary sequestrations have no normal connection with the bronchial tree. They have a separate pleural covering. They get their arterial supply from the aorta, and their venous drainage goes back systemic. They're most often in the left lower lobe, and they have associated abnormalities which can include congenital heart disease and diaphragmatic abnormalities. It's thought to be due to a supernumerary lung bud that buds off distal to the normal lung bud at between 5 and 7 weeks of gestation. Now, at 5 weeks, the esophagus and the trachea are still one tube, but by 7 weeks, they've divided into 2 tubes. So depending on when this occurs, you can end up with the whole spectrum of bronchopulmonary foregut malformations. If it's already divided into a trachea and an esophagus and you have a little extra bud, you'll end up with a bronchogenic cyst. Here is one that's off of the esophagus. This is an esophageal duplication cyst. These are defined by what their lining is. Is it esophageal mucosa or is it bronchial mucosa? So you can have an esophageal bronchogenic cyst, and it's defined pathologically. Now, the other thing is if this lung bud comes off very distally, it may be down in the abdomen. And here you can see there's a cystic and solid mass in the upper abdomen posterior to the spleen and separate from the adrenal gland. And this turned out to be a cystic abdominal pulmonary sequestration. So this is a sequestration that's clear down in the abdomen. The next case is a 2-year-old boy with stridor. And here's his frontal chest x-ray where we could see that if anything, his carina looks low to me. And on the lateral view, if we look very carefully, we can see a posterior indentation on the trachea. When we do an upper GI on this child, here's the trachea with this posterior indentation. Here's the esophagus with an anterior indentation. On his MRI, you can see the main pulmonary artery. Here you can see the right pulmonary artery, and then coming off the right pulmonary artery is the left pulmonary artery. So this is a pulmonary sling, which is anomalous origin of the left pulmonary artery from the right pulmonary artery. And it goes back between the trachea and the esophagus. There's usually associated tracheal stenosis or tracheal malacia. So even if they fix the pulmonary arterial problem, these children may still have respiratory difficulties. Rings and slings. This is a favorite board topic, and it is a topic of real life as well. When you do upper GIs on babies, we always look to see if there's any indentation on the esophagus. If there is posterior indentation on the esophagus and anterior indentation on the trachea, you think about a vascular ring, with the most common of which is a double arch. If there is posterior indentation on the esophagus but no indentation on the trachea, that's usually an aberrant right subclavian artery. The pulmonary sling we've talked about, where there's posterior indentation on the trachea, anterior indentation on the esophagus. The fourth pattern, where there's only anterior indentation on the trachea, is probably a normal variant. So here we have a child that has a posterior indentation on the esophagus, and on his MR that was done for other reasons. You can see that there's an aberrant right subclavian artery. Here it is coming off. There it is going out to the right arm. Here's a child who has deviation of the trachea to the left. We can see at least a right arch. When we do the upper GI, we can see a posterior indentation on the esophagus, anterior indentation on the trachea. Here's the right arch, and here's the left arch on the frontal view. And here's this child's MRI, where you can see the larger right and the smaller left arch. Here's the larger right arch, giving rise to the right-sided arterial vessels to the head. Here's the left arch, giving rise to the left-sided. And then here's the descending right aorta that's crossing to the left eventually. So this is a double aortic arch. Okay, abdominal masses. This is a newborn with an abdominal mass, and we can see that there's a large abdominal mass displacing bowel to the left. By ultrasound on this longitudinal image, we have a very complicated mass with a fluid level that's either necrosis or hemorrhage within it. Here's the MRI on this child. The left kidney was normal, but here's this large mass in the right abdomen, and this is a mesoblastic nephroma, or fetal renal hamartoma. This is the most common renal tumor in newborns. Wilms tumor is very, very uncommonly seen under a year of age. So if you see something that you want to think is a Wilms tumor, but the baby's only a month or two old, think instead about a mesoblastic nephroma. These usually are benign tumors, but they are on the spectrum of benign to malignant spindle cell sarcomas. And even if you have the benign form of a mesenchymal hamartoma, there have been reported metastases from it. An abdominal mass in a newborn is usually benign and usually of renal origin. And over half of them are of renal origin. And the most common group is hydronephrosis, all the different causes of hydronephrosis, UPJ, UVJ obstruction, reflux, posterior urethral valves, the whole thing. The most common single diagnosis is multicystic dysplastic kidney. And other things that you can see, mesoblastic nephromas, the kidney becomes very swollen if there's a renal vein thrombosis, so that can present as an abdominal mass, and polycystic kidney disease. Here's a multicystic dysplastic kidney. You can see a big mass displacing bowel to the right. It's a general rule in a baby that masses that are outside of bowel origin will push the bowel around but will not obstruct it. If you see a bowel obstruction, then you think of a bowel origin mass. And here you can see on the ultrasound, there's multiple cysts that don't connect. There's no normal renal parenchyma. And on this DMSA scan, here's the normal right kidney, no function on the left kidney. Very typical findings of a multicystic dysplastic kidney, which is felt to be a piloinfundibular atresia very early on, and no normal development of the kidney. So there's sort of the end spectrum of an obstruction. Other abdominal masses in neonates, about 15% are due to genital causes, such as hydrometrocopos or ovarian masses. Now remember in babies, that baby girls, that the pelvis is very small. So the ovaries are actually intra-abdominal structures, and they can present subhepatic in position. And this is, you can see here's liver, here's kidney, here's a hemorrhagic mass with a fluid level within it, a well-defined wall, and this is a hemorrhagic ovarian cyst in this baby. All the way up subdiaphragmatic, not uncommon in neonatal girls. Gastrointestinal masses account for about 15%. These can be duplication cysts, mesenteric or omental cysts, or a complicated meconium ileus with, where there's been some kind of a bowel perforation and meconium pseudocyst. Non-renal retroperitoneal masses account for about 10%, and those can be either adrenal hemorrhage or neuroblastoma. A neonatal adrenal hemorrhage is pretty common, and it's felt to be due to perinatal stress. It can be birth trauma, hypoxia, dehydration, and these kids will often be shocky, and then they'll become anemic and jaundiced because they've hemorrhaged into their adrenal gland. The hemorrhage is more common on the right, but can be bilateral, and you'll see this complex mass sitting on top of the kidney, and the clinicians will be able to palpate it. I don't know why this particular baby got a CT scan. You do not need to CT scan adrenal hemorrhage, but it's just a nice example to show you that it looks like a inhomogeneous but hypodense mass displacing the kidney inferiorly. The important thing is that you follow these suspected adrenal hemorrhages to resolution. And here you can see several months later there's a calcified adrenal gland sitting on top of a normal appearing kidney. The reason is that you can be born with a neuroblastoma, and you can have hemorrhage into a neuroblastoma. So you want to make sure that that's not the case in these infants. So just do a follow-up ultrasound after a few months and make sure it's gone away. Hepatobiliary masses are uncommon, only about 5% of abdominal masses in neonates. Metastases are the most common liver mass in children. So when you see a liver mass, always remember to think about metastases such as neuroblastoma or lymphoma. Hemangioendotheliomas are very common. They have elevated AFP levels, and they're vascular proliferative malformations that occur over the first 18 months of life, and then they regress. Hemangioendotheliomas do not have elevated AFP levels. They have normal AFP levels. Hepatoblastomas have elevated AFP levels. They are uncommon masses, but pretty typical in appearance in the neonate. Mesenchymal hamartomas are benign tumors, and then choledochal cysts are, as I showed you before. Here's a hemangioendothelioma of the liver. It's a hypercellular tumor. There's AV shunting. So that's one of the main differentials of it from a hepatoblastoma is typically they'll classify that hepatoblastomas do not have AV shunting. So if you see an abrupt caliber change in the aorta after the takeoff of the celiac, and if you see big hepatic veins, think about a hemangioendothelioma. These patients will often present with congestive heart failure, anemia, and jaundice. They may have sequestration of platelets, that's Kasabach-Merritt syndrome, and it can be hard to tell these lesions from hepatoblastomas, but by measuring the AFP and by putting all the pieces together, you can usually come up with the diagnosis. Here you can see this large intrahepatic mass with central necrosis, peripheral enhancement involving the majority of the right lobe and left lobe of the liver. The next case is a 14-year-old boy with back pain. He had neuroblastoma as an infant, and you can see on this CT scan that he has intrarenal masses. Here's one here. There's a second one that's going to be sitting over here. This one's hypoechoic. This one's a little, or hypodense. This one's hyperdense. There's another one right here. This turned out to be renal cell carcinoma. And renal cell carcinoma after treatment for neuroblastoma appears to be a distinct clinical entity. And I bring this up because there are more and more children who are surviving high-stage neuroblastoma that you're going to see in adult populations. And these kids need to be screened for renal cell carcinoma. It can be bilateral. It's not related to the chemotherapy they got or the radiation therapy they got. There have been cases where the neuroblastoma was in the neck and the kids present with renal cell carcinoma. So it's probably part of a cancer syndrome, and it's only now that we're starting to see the children survive that we're starting to pick this up. Now, if we move out of the neonatal period to children, again, renal masses inside Gerota's fascia predominate as the cause of abdominal masses in kids. But now we move the malignancies up on our list. Wilms tumor becomes the most common. Renal mass and hydronephrosis falls down to second. Again, cystic disease, other benign tumors are also on the differential list. Wilms tumor, which this is case 2, is the most common renal and abdominal tumor in children. That being said, there are only about 500 cases in the United States that are newly diagnosed each year. So the places that you've been at in training in academic centers, you're getting a very skewed view of the number of Wilms tumors that are out there. It's usually a hyperechoic mass on ultrasound and a hypodense mass on contrast-enhanced CT, and you can see the normal renal parenchyma here, and you can see actually there's tumor involvement in lymph nodes adjacent to the kidney. When you're looking at what you think is a Wilms tumor, you need to look at the primary tumor extent. You need to look for vascular invasion. Here you can see in the inferior vena cava there's tumor growing into the inferior vena cava here. You need to look at the opposite kidney to see if it is involved, because Wilms tumor can be bilateral. And you need to look for metastatic disease, which occurs most commonly to the lungs, but it can also occur to the liver. Now, the staging, you can't completely stage a Wilms tumor unless you see it bilaterally or unless you see metastatic disease, because it's a surgical staging system. Stage 1 is limited to the kidney and completely removed. Stage 2 is beyond the kidney but completely removed. Stage 3 is residual tumor in the abdomen. 4 is metastases, and 5 is bilateral involvement, which may be not at the same time. Multilocular cystic nephroma is a benign cystic mass. It has multiple thin septa. It's typically in the pediatric population seen in young boys, and then there's a second bimodal peak in older women. These usually have to come out to make sure that they're not Wilms tumors. Lymphoma can appear in the pediatric population as a single renal mass, multiple renal masses, diffuse infiltration of the kidney, or an extrinsic mass that obstructs the kidney. And here you can see multiple hypodense masses involving both the pancreas and the kidneys. It's a favorite board question to be showing you a case that has hypodense or hypoechoic lesions in either the kidney or the pancreas. And people want to run down the cystic masses and talk about von Hippel-Lindau and things like that. Remember that everything that is hypoechoic or hypodense is not cystic. And remember to think about lymphoma. Rhabdoid tumor is a very bad tumor. It's a highly malignant neoplasm. It's usually seen in kids under 5 years of age. And if you see what you think is a Wilms tumor, but you have bony metastases or brain metastases, think instead that you're probably dealing with a rhabdoid tumor. And here you can see a very large intrarenal mass. There you can see the nice claw sign of this arising out of the renal parenchyma. And there's a mass at the left side of the quadrigeminal plate and hydrocephalus resulting in this child. Non-renal retroperitoneal masses account for another quarter. So between the renal masses and the non-renal retroperitoneal masses, we get 3/4 of the abdominal masses in kids, and the most common is neuroblastoma. Second most common is rhabdomyosarcoma. Gastrointestinal and biliary account for about another 1/5 of abdominal masses in kids. Appendiceal abscesses and intussusceptions top that list. Here's an older child, and you can actually see that he has an intussusception into the cecum, and when you look at his CT scan, he has diffuse thickening of bowel, and this was Burkitt's lymphoma. So again, if you have a child over 2 years of age with an intussusception, think about a lead point, and that most common lead point is lymphoma. 10-year-old girl with abdominal pain. Here we can see that she has a soft tissue mass in her left mid-abdomen. On CT, we can see this is a hypodense mass. There's some rim enhancement around it. And we could see a whorled appearance in the mid-abdomen, and we do not see a normal spleen. Here's the left upper quadrant, even up a little higher. And this was torsion of an ectopic spleen. If the supporting ligaments around the spleen are absent, the spleen can twist, and the findings are pretty much what I just showed you here. The spleen is not in its normal position. It inhomogeneously and often doesn't enhance. You'll see vascular thrombosis, or you'll see that whorled appearance of tissue in the hilum of the spleen. Other splenic abnormalities, you can have the asplenia and polysplenia complexes. You can have accessory spleens, that's very common. And you can have vascular malformations in the spleen, as the hemangioma that was shown in the last talk. Acquired abnormalities, splenomegaly, can be due to chronic liver disease. It can be due to leukemia or lymphoma, metabolic disorders, hematologic disorders like spherocytosis. You can have splenic cysts that can be very large. You can have infection of the spleen. And then you can have hemorrhage after trauma. The next case is an 11-year-old with hemoglobin SC disease who had abdominal pain. They found that his pancreatic enzymes were elevated and sent him for CT because of that. And here we can see that his pancreatic duct is dilated, but we also see that he has this very inhomogeneous mass filling his stomach and into the duodenum. Here you can see it here, and this is what it looked like when it was resected. This is a trichobezoar resulting in obstructive pancreatitis. And one thing I learned from this case is that it's actually pretty common to have pica in sickle cell anemia somewhere in the course of their lifetime because of the anemia. It can result from either iron deficiency or zinc deficiency, although the exact etiology is not known. This particular patient was eating human hair, doll hair, and carpet. The next case is a 3-year-old with bloody diarrhea, and here you can see that there's a very classic thumbprinting appearance of the transverse colon and overall aposity of bowel gas. When we ultrasounded this child, we can see hyperechoic kidneys and ascites, and then when this child became obtunded and on a head CT, we can see low density in the basal ganglia and thalami bilaterally. And this is hemolytic uremic syndrome, which is the triad of acute renal failure, microangiopathic hemolytic anemia, and thrombocytopenia. These kids can have colitis, and the colitis may present before the renal failure, the CNS malformations because of that thrombocytopenia and then clotting. Can be very, very devastating, and actually the child I just showed you died as a result of the hemolytic uremic syndrome. They can have rhabdomyolysis, and they can have diabetes. It's usually seen in kids that are 1 to 5 years of age. An infectious agent may be the initial stimulus, such as an endotoxin. They don't know for sure, but that results in vascular endothelial damage that causes fibrin formation that damages the red cells, and then you get vascular congestion in the organ systems, and that's why you see the abnormalities that you do in the kidney, in the CNS, and the GI tract. The next case is an 18-month-old who stopped walking over several days. And if we look carefully on this child's lateral view of the spine, we can see that as we march down here, there's disc space narrowing at the L4-5 level. Here's this child's MRI, and we can see that there's abnormal signal in the disc on T2 weighted images and abnormal enhancement on the vertebral body end plates on either side of the disc and also surrounding the disc. And this is a case of discitis, which is case 3. This is an inflammatory process of the disc space. Half of kids will culture positive for Staph aureus. It's most common in 6 months to 4-year-old age kids. Kids are not very good at localizing their pain, so I just remind you that if somebody comes in and says they have hip pain and you don't see anything in the hip, you need to look at the knee and the back, one joint on either side of where they're complaining of their pain, because they're not always very good at telling you where they really hurt. The radiographic findings for discitis include disc space narrowing, adjacent marrow edema, and you can see enhancement of the disc and vertebral body end plates. So it can be subtle, but watch for that because you look like you're a star when you find it. The next case is a newborn infant who seems to have pain when the nurses move his arms and his legs. The baby has a hypoplastic left heart, so we would expect to see a big heart and vascular congestion, which we do here, and this child is intubated. But you can see that there's diffuse periosteal reaction involving pretty much the clavicles, the humeri, lesser degree to the ribs, but everywhere. And so we can talk about our differential of periosteal reaction in infants. You can have physiologic periosteal reaction, which is just a result of rapid bone growth. You can have periosteal reaction from infection or inflammation, such as the torch infections. You can have it from metastatic disease, such as neuroblastoma or leukemia. You can have it as a result of trauma, and we always think about non-accidental trauma in children. We can see it as a result of metabolic abnormalities, scurvy or hypervitaminosis A, and then Caffey's disease, which is a not very well-defined periosteal reaction, often involving the mandible, thought to be an infectious agent, but nobody really knows. I've only ever seen one case of that. This particular case is prostaglandin-induced periostitis. Prostaglandin E is used to maintain ductal patency in kids that have ductal-dependent heart disease. Prostaglandins cause bone reabsorption, and you see periosteal reaction in kids that have long-term administration. It's often asymmetrical. It seems to be painful. And it's not related to the dose. It's more related to the duration that they receive it. And in some places in the country, kids that have hypoplastic left hearts receive heart transplants as their treatment. So while they're waiting for a heart transplant, they need to keep the duct open, and that's why they're giving the prostaglandins. Here's an example of physiologic periosteal reaction. It's more common centrally. It's bilateral and symmetric, and you'll always see it proximal before you see it distal. So if you see periosteal reaction on a tibia and you don't see it on the femurs, it is not physiologic periosteal reaction. It's most common in the femur and the humeri, bilateral and symmetrical, up to about 6 months of age. Here's a child that you can see irregularity of the metaphysis, and we see periosteal reaction. We see soft tissue swelling about the ankle. If you remember, the metaphysis is a favorite place in kids for getting osteomyelitis because of the curved, slow-flowing vessels in the metaphysis, and this is a case of neonatal osteomyelitis. Here we see a very typical bucket handle fracture at the distal tibia, and this is a favorite location for bucket handle fractures, and here's some periosteal reaction as it starts to heal. This is also a corner fracture, which is the same thing as a bucket handle fracture of the distal fibula. Basically, in young infants, the zone of provisional calcification, where the chondrocytes are dying but the bone has not yet ossified, is the weakest part of the metaphysis. It's weaker than the ligaments. So if there's a twisting injury, that's what tends to break, and that's why the bone that's ossified, the calcified bone just distal to that, that's why you can see it. That gives you your corner fracture or your bucket handle fracture. And it just depends whether you're looking at it straight on or obliqued, whether you call it a corner fracture or a bucket handle fracture. The next case is a 3-year-old with hearing loss, and we can see that there's diffuse bony sclerosis. You can see a beautiful bone within a bone appearance at this pelvis and also in the vertebral bodies. This is a case of osteopetrosis, which is a complex disease of at least 4 types. This one is the autosomal recessive lethal type. These children tend to be short. They have hepatosplenomegaly and hydrocephalus and cranial nerve dysfunction because of the encroachment of the expanded bone on the neuroforamina. Marrow encroachment also results in anemia and thrombocytopenia, and they usually die because of infectious complications. There are other types that are less severe as the person gets older. The next case is a young man with height in the 10th percentile and waddling gait. Now I have to tell you, everybody freaks out about dwarves, and dwarfisms and syndromes are important. They're more common than congenital heart disease, but there's no such thing as a dwarf emergency. So the big thing is that you have to have an approach to what you're going to do for your dwarfs. And if you don't know what it is, you need to be able to try to at least classify it into where you think that, what bones you think are involved. Do you think it's rhizomelic, mesomelic, acromelic? Do you think it's epiphyseal, metaphyseal? Do you think the spine is involved or not? And then If you can get that far and then say, okay, well, here's what I think my major features are, and here's the books I use, or here's the resources I use, you're going to go a long way in that case. You probably won't get shown more than one dwarf if you get shown a dwarf on the board. And actually, you know, the number of syndromes and dwarfs that we see in pediatric radiology is declining over the years as these are being diagnosed in the fetal population and are terminated. So, there are a few common dwarfs that are survivable dwarfs that you will see. Achondroplasia is obviously the most common. There are a few others, but don't panic about the dwarfs. So here's a child that's short, and you can see that he has spine abnormalities. He has flattened vertebral body with irregular end plates, and his epiphyses look weird. So this is spondyloepiphyseal dysplasia, very common. That's one of those 10 that you're going to see. The metaphyseal dysplasias you'll see, achondroplasia you'll see. Those are probably the three biggest ones. Diastrophic dwarfism I'd put on the list as well. Things like thanatophoric dwarfism and achondrogenesis I haven't seen in years. Those are all diagnosed prenatally. Spondyloepiphyseal dysplasia tarda is an X-linked recessive disease, so it's seen in boys. It usually becomes evident at 5 to 10 years of age. They have irregular flattened epiphyses. They can get premature osteoarthritis. They have short trunks and platyspondyle and can have odontoid hypoplasia. So that's an important thing to know. Pretty much in all the dwarfs that you look at, remember to think about looking at the neck, because if they're going to do any kind of orthopedic procedure or surgical procedure, it has to be safe to intubate them, and a lot of these can have instability at C1, 2, or at the occiput C1. The next case is an 11-year-old girl with short stature. Here you can see there's shortening of the fourth metacarpal and delayed bone maturation. The differential diagnosis of a short fourth metacarpal, and I specifically put this case in a couple of years ago because somebody came up to me after I had spoken and said, I got shown Turner syndrome on the board. So here it is. At least a couple of years ago, somebody showed Turner syndrome. The differential diagnosis of a short fourth metacarpal is a normal variant, Turner syndrome, pseudo hypoparathyroidism, acrodystosis or Leary-Wheel disease, multiple epiphyseal dysplasia, or you can get acquired abnormalities because of chronic arthritis or trauma. Turner syndrome, which was case 4, is XO genetic makeup. It's seen in 1 in 5,000 live births. They tend to have short stature with a webbed neck and a low hairline, a shield-shaped chest. Remember that if you think that you're dealing with Turner syndrome, you need to go the extra step and say, well, gee, we need to look at the aorta because they can have aortic stenosis or coarctation of the aorta, and they can also have horseshoe kidneys. And these girls will also have primary amenorrhea. Here's another patient that has shortening of pretty much all of the metacarpals, but you can see that there's metastatic calcification in the right supraclavicular region, and this is pseudo-hypoparathyroidism. The next case is a 3-year-old who is refusing to walk, and you can see that there is a sclerotic lesion in the left iliac wing. Here it is on CT. You can see that there's a proliferative, irregular, mean-looking mass here with a large associated soft tissue mass. It's amazing to me that this kid did not present with bladder symptoms because his bladder is squished clear to the opposite pelvic wall, and I think he probably did have bladder obstruction. This is Ewing sarcoma, which is the second most common primary malignancy of bone. Osteosarcoma is the most common primary. Most of them arise in the extremities, but if you see a tumor in flat bones, it's more likely Ewing's than osteosarcoma. Pelvis, ribs, most likely Ewing sarcoma. It can be metaphyseal, so when you're looking at a tumor and you think it might be an osteosarcoma, at least have it cross your mind whether it could be a Ewing sarcoma as well. And if you see a diaphyseal tumor, bring Ewing's way up to the top of your list. The other main differential you would have is lymphoma. It's a highly variable appearance. It can be lytic, it can be sclerotic, it can be anywhere in between. You'll see destroyed bone. It'll look like an aggressive lesion. You may see periosteal reaction. The classic is onion skin periosteal reaction, but frequently it's not onion skin. Okay, this case, we can see that there is irregularity of the toes, where we've reached the feet here, and we can see that there is a large expansile lesion that communicates with the medullary space. There's a second and third lesion here, and this is multiple hereditary exostoses, which is an autosomal dominant disease, and these are, some people feel are developmental abnormalities, some people think they're tumors. But they are protuberances of bone, and you can see associated deformity of the bone and shortening of the bone, and they have a cartilage cap on them, and they only develop in bones that develop by enchondral ossification, so you do not see these in the flat bones of the skull, etc. Complications can include fracture, osseous deformity, compression of nerves, compression of vessels, bursa formation, pain with movement, and in about a quarter of people, you can see malignant transformation. That tends to occur more centrally than more peripherally. So if you see growth of an osteochondroma after puberty, then you start to worry about malignant transformation. You can also see, if you look at the MRI, if they get a real thick cartilage cap, that would raise your suspicion that these might be malignant. So that's it from head to toe, and good luck.
Now, I'm going to show you unknowns. I'm going to show you the findings you should have seen. I'm going to talk about what the differential diagnosis is, and then I'm going to tell you what it is. Or maybe you're going to tell me what it is if you feel like shouting out the answer. I don't really care. But let's start with the first case. But before we start with the first case, when you're sitting in the GU section, it's really important to look at the case ahead of time. I mean, you try to look at all the cases before you speak, but once in a while you start to moan or cry. That doesn't count, okay? So you look at the case and you decide in the GU section whether or not contrast has been given. And if it has been given, by what route? Because your examiner may be a mean person and say, gee, have you ever done an IVP or an excretory urogram? And you're, kind of embarrassed and saying, well, gosh, in the early Pleistocene, they talk about it. But, don't insult the examiners. By and large, they are older than you are. Show them respect. Okay, so first case here. We've got a retrograde pyelogram. And what you should have noticed is a filling defect up here in the renal pelvis. And that differential is crossing your mind very quickly, and you're thinking, calculus, neoplasm, blood clot, fungus ball, etc. And when we go back, we look at this irregular morphology here, this irregular luminal filling defect, and we realize, of course, that it's a transitional cell carcinoma. And all of this information is in your handout. Remember, there are risks. There are natural and not so natural things that we like to use in life. Artificial sweeteners, I guess. No one really likes Cytoxan. But at any rate, I want to point out, for those of you who have never seen it, Bergman sign. Remember that when you have a lesion in the ureter, it can prolapse back and forth in the ureter in sort of a, not exactly ball valve type of thing, but as the lesion itself prolapses a little bit distally, it actually causes dilatation of the ureter distal to the level of the obstruction. It's also called the goblet sign. Remember that transitional cell is multicentric in up to 30%. So when the examiner says, how do you treat this, doctor? Well, of course you do a nephroureterectomy, but before you do that, you want to make sure you've clearly investigated the rest of the urothelial tract. And you want to make sure you've put a lot of attention looking at the bladder. Okay, next case. You'll see that there's this odd-looking device over the pelvis, and that is a compression device for those of you who don't do IVPs anymore. This is, in fact, an IVP, and what I want you to notice is that there is a small central papillary cavity which communicates with the nadir. Oh, doesn't that sound sophisticated? Of the calyceal concavity. If you can get those words out of your mouth, then you know what the diagnosis is. Papillary necrosis. Remember that it's bilateral and up to and sometimes more than 85% of the time. The kidneys, may develop these fissures. Other things to consider in that differential diagnosis. Well, first of all, know the causes of papillary necrosis. Postcard is one mnemonic that you can easily remember. At least you can remember it tonight when you're sitting there. You're going to kind of go, tumor, neoplasm, infection. You'll say things over, and But other things to consider that don't exactly look like this, but renal TB is something, if it just involves a single calyx and it looks rather distorted, is something you need to exclude. Remember that calyceal diverticula arise from the fornices and not from the central portion of the collecting system. Now, here's something you'll look at, and you'll say, oh, by the way, always look at the bones in the GU section, because there are many GU problems that affect not only the urinary tract, but also the bones. I'll give you some examples a little bit later, but look here and you'll say, don't say something like this is a skeletally immature individual. It's okay to say it's a child or an infant. Those words are acceptable. You'll notice that this is not sort of the normal morphology of a little tyke. And you're seeing lots of contrast here in what are meandering ureters with markedly dilated pelvises and blunted calyces. And once you've made all those observations, you'll recognize it as prune belly syndrome. It's the bulging flanks. Remember that prune belly syndrome is a constellation of findings which includes all of these GU abnormalities. The postulated mechanism, believe it or not, is a hypoplastic prostate, which causes a twisting, if you will, at the level of the prostate. And I tend to think of it as an obstruction at that level, and then everything else backs up. So you've got increased pressure, my simplistic mind thinks, increased pressure, distended bladder, urachal cyst or diverticulum, since that comes off of the dome, and then hypoplasia of the abdominal muscles. I think of them ballooning out. You can have urinary ascites. The testes do not descend. There is no abdominal muscular pressure to help them descend. Of course, they also follow the gubernaculum south. But remember that there are classifications. I doubt that you'll have to get that far. What's on the differential? Well, hopefully they'll show you a nice example of posterior urethral valve. Urethral stricture doesn't usually occur in neonates. Bladder neck obstruction, anterior urethral diverticulum are possible, but they don't quite look the same. That's almost an Aunt Minnie. Okay, moving on. Now, look at the film. Has contrast been given or not? Okay, no, it hasn't. And what we see here is a large staghorn calculus in the right kidney. We also see something that looks rather unusual, which is, believe it or not, a gas-filled ureter on the left. And because I told you to always look at the bones, and because I, of course, am a mean, nasty person, I didn't show you the symphysis pubis, these ilia are rotated outward. And this is what exstrophy looks like. If you've never seen it, now you've seen it. Now, why do we get all these findings? First of all, in the good old days, like probably in the Pleistocene, all of these kids had urinary reflux. They still have urinary reflux. So the ureters were reimplanted. And they used to be implanted into the sigmoid colon. Well, that doesn't sound like a good idea now in the 21st century. But back then, or as my daughter would say, back in the day, we got reflux, and reflux caused infections in the kidneys, and that's why you're seeing gas in this kidney. So remember that it's uncommon. I know you'll remember that. The rectus muscles do separate, and it's also associated with the ilia being rotated outward. What are the complications? As I stated, ureteral reflux, cystitis glandularis, which pops up every now and again on the written boards, but hopefully you're all past that, and of course, bladder carcinoma, 200 times more common. So your examiner might say, in a patient with bladder exstrophy, what's a complication? Adenocarcinoma of the bladder. Moving right along. Okay, we've got another KUB, and you're looking, gee, why is she giving me this case? Well, I want you to notice that this is a child. Notice that there are some unfused bone bits here. If you look in the left upper quadrant and you have eagle eyes, which is hard after dinner, there's a calcification. Now, you see this faint calcification, and I give you a CT scan. And on the CT scan, we see essentially a calcified adrenal mass in a child. So immediately your mind leaps to the diagnosis of neuroblastoma, which is the most common childhood neoplasm, and you know to check for catecholamines. You know that it can be unilateral or bilateral. And these are all the findings we look for with imaging. Staging. Remember that neuroblastoma is that funny disorder that has the 4S, skin, liver, and marrow. The differential, exophytic Wilms. Okay, Wilms can calcify, but rarely. Same thing with mesoblastic nephroma, doesn't usually. Multicystic dysplastic kidney can, but of course these are all renal tumors, not adrenal tumors. So retroperitoneal teratoma and adrenal hemorrhage, which is calcified, would be the two that you'd be thinking of. Okay, what we have here is irregular intrauterine filling defects on an HSG. Now, I want to say a couple words about HSGs. If you've never done one, don't be embarrassed to say that at the boards. Don't lie. Don't make it up. Someone will ask you a question, and you will look stupid. And you don't want that to happen. So, as a matter of fact, I never did one as a resident. But know how they're done. I mean, read Winfield's book, just the part on how to do an HSG. Ask one of the faculty at your institution, gee, what's our routine here? You know, just have something that you can say. My former mentor, who is now the chairman of radiology at Sloan Kettering, would come back and tell me about examining residents on the boards, and she said, gee, I got the greatest response this year. And I asked my resident, I said, when do you do HSGs? And the resident said, in the afternoon. She said, why do you do them in the afternoon? And the resident said, oh, because we do the GI fluoro in the morning, and it's the only time we can use it. So that's a good answer. A rather insipid one, but not the one you want to give. Okay, so know, when you're supposed to do the HSG in the first 10 days of the menstrual cycle, yada, yada, just read up on it. Okay, this is Asherman syndrome, not a difficult diagnosis to make. It's the synechia, and again, they're thought to be iatrogenic, although less frequently now, but you can see them post-infection or inflammation. What would be on the differential? Well, if you diagnosed endometrial carcinoma this way, you deserve the Nobel Prize. No one does it anymore, but again, it's something that could be in there, and maybe the patient's not getting pregnant because she has endometrial CA. Unlikely. DES, the DES uterus is small and T-shaped, so make sure you've taken a good look at the size of the uterus, and polyps. Sometimes they can be irregular and confluent, but the scarring is fairly characteristic. Okay, I got this case on my boards, and I will never forget it. I got it in the pediatrics section. And that's one thing to remember, that darn pediatrics section. They can ask you Peds cardiac, Peds neuro, Peds GU, Peds bone. So it's like you get all the sections all over again, So I got this one. And, after you've given it a good look, you say, the posterior urethra is abnormally enlarged, and there really is only one thing that does that. The posterior urethral valve, the most common type being the type 1. It's still equivocal whether or not type 2 really exists or whether type 2 merely represents just a variation which has been called a valve but is not really a valve. And then the iris diaphragm type. Complications, all these kids get vesicoureteral reflux, renal dysplasia, on and on. But what's on the differential? Severe reflux, okay, but it won't dilate the posterior urethra. Prune belly can again give you generalized dilatation of the GU tract, but looks different. The big thing is the anterior urethral diverticulum, but that's not what this is. It's a posterior urethral valve. Next case. Again, you're looking at the CT. One is pre-contrast, and the other one is post-contrast. And again, it's in a child, changing your differential diagnosis dramatically. If this were an adult, bilateral renal enlargement with this kind of enhancement would be vanishingly rare, but lymphoma would probably be number one on your differential. but it's nephroblastoma, and it has a very characteristic appearance, which I just showed you. Remember, the nephrogenic blastema, if it persists beyond 3 weeks, can cause nephroblastoma, and that it's a Wilms precursor. Differential mesoblastic nephroma, or the fetal renal hamartoma, but that is a solid lesion, doesn't really enhance like that. Renal cell carcinoma, of course, can occur in childhood, so you always have to put that on the differential. Now, an MRI. Okay, a body MRI. Oh, horrors. You have to, when you get an MRI, try to figure out whether it's T1 weighted or T2 weighted. This is a little bit tricky because I'll tell you, this is proton density weighted. The urine is still dark, but this little focus right here, which is a cyst projecting posteriorly from the prostate, is high signal intensity. Now, it could just contain a lot of mucinous material and be a T1 weighted image, but you won't see the other anatomy as well. It's proton density. It is, in fact, a Müllerian duct cyst. They arise from the verumontanum and they extend above the base of the prostate. They usually present themselves sometime around puberty or early adulthood because prostatic secretions that arise from the sinoutricular plate get blocked and caught up in this cyst. There is no sperm or fructose in them, which is unlike seminal vesicle cysts, and there's no anomalies of the external genitalia, which is what you see with the prostatic utricle, or you may see with the prostatic utricle. Complications, though, remember stones or a small but significant, or should be mentioned, increased incidence of adenocarcinoma and squamous cell carcinoma. The prostatic utricle is often, when it's significant, when it's a large utricle in particular, there's a grading system for prostatic utricles that's more than you need to know. Okay, but those are associated with ambiguous genitalia or hypospadias. And they're noted in infancy. They don't present suddenly, at the age of 13 or 14. Seminal vesicle cysts, recall, are not in the midline, and they are associated with renal agenesis. Okay, this is an IVU, and we see marked bilateral ureteral dilatation. So going through your mind, you're thinking of reflux, you're thinking of blah, blah, blah. You're thinking of primary megaureter, which is what this is. I kind of remember it as the Hirschsprung's disease of the GU tract, where you have this juxtavesical segment, which is aperistaltic, and you get a functional obstruction with dilatation. Remember that there are associated anomalies in slightly less than half cases, contralateral renal agenesis and ipsilateral UPJ. You're not going to get that far. When you get to primary megaureter, they're going to say, well, how do you know it's a primary megaureter? And you're going to say, well, it could be a refluxing megaureter, which is far more common than primary megaureter. We see vesicoureteral reflux all the time. You want to make sure there's not an obstruction distally or urethral valves. There could be an obstruction distally, the like, and then the non-refluxing, non-obstructing megaureter, which is what we've shown here. And diabetes just from high flow rates can sometimes cause this generalized dilatation. Okay, next case, we're looking at a ureter, and we see multiple intraluminal ureteral filling defects. This is kind of an Aunt Minnie pyloureteritis cystica. Remember, Brunn's cell nests, they can range in size from 1 millimeter to 2 centimeters, and they're associated with chronic inflammation and UTIs. What else can look like that? Well, this would have to be a lot of papillary transitional cell CAs. But if you just see a few of these things, it's clearly on the differential. And you want to make sure that these things are actually intraluminal filling defects as opposed to ureteral impressions from the outside, from vascular things, or that they're not ureteral pseudodiverticula. Okay, next case, we see a hypodense mass in the left kidney. This one's pretty straightforward. Angiomyolipoma, more common in patients with tuberous sclerosis, in which case in patients with tuberous sclerosis, they're bilateral, but middle-aged women are the other peak. They're hypervascular, have pseudoaneurysms. I actually, in one hospital, saw a woman, didn't see her personally, but we had a case of a woman who actually bled to death when one of these things ruptured. And this is a patient who has bilateral angiomyolipomas with bleeding into these. These look angry and nasty. When they're bilateral and they're mixed density, then you can, you're pretty sure of what the diagnosis is. Very often the angio-interventional guys get involved and have to coil these things. Differential, of course, is a renal cell carcinoma if it's unilateral. If there's a lot of fat, a lipoma or liposarc. Okay, here's a case, garden variety ultrasound. The tech calls you in and says, take a look at this case. Actually, the tech probably doesn't even notice this. The tech brings the case in and hands it to you, and you have to sit there and go, oh, wow, look at these echoes in the collecting system. Is that real or is it just an artifact? Well, these are real, and this is what candidiasis can look like. Remember that candida in the kidneys can present as renal parenchymal candidosis, which is probably the most rare, where you get actual microscopic abscesses, and it can also be manifest itself as urothelial thrush, which is just invasion of the renal pelvis in the ureter, or what we see most commonly is cystitis. Differential diagnosis, remember, anything that fills up something in the collecting system in the GU tract has this differential. Blood clots, calculi, cancer. Make sure it's not just air bubbles, debris, polyps, etc.